So that looks good. Hi, Eduardo. ¿Cómo estás? So we can start. Are we online, Priya?
Yes, online.
Hello?
Yeah, okay. Then we
Yes.
will start. Hi, Eduardo. So good afternoon, everyone. We are starting the afternoon session, and it is not only my great honor, but also my very pleasure to introduce to you Professor Eduardo Targarona, who is from Barcelona, from Spain, and who is a very well-known surgeon in Europe and all over the world due to the fact that he has been the president of EAES. He is the actual president of the Spanish Association of Surgeons. He has been at the forefront of development of laparoscopic surgery and minimally invasive surgery, specifically in the field of digestive surgery. As myself, he graduated, by the way, in the same year, Eduardo, and I was not far away from you in the south of France. So that was back in the year 1979. Since then, he had an excellent career, progressed to a professor of surgery at the University of Barcelona, had some experience in England, in Dundee and in London, as well as in Paris and France. So a very bright career. And he will be talking now to us on the everlasting topic since we started colorectal surgery, how to do the anastomosis after a right hemicolectomy, either laparoscopically fully or extracorporeal. So I'm very curious to hear, Eduardo, what are the new evidences, which technique is better, where are the risks and where are the benefits. So the floor is yours, por favor, cisplau.
Thank you very much for your kind introduction. Sorry. You see the slides? The slides are okay? Okay. Well,
Perfect.
Professor Hartung, leaders of the ELSA, David Lomanto, SUTEP, good dear friends. It's a big pleasure, really, to have the opportunity to address to you in this virtual Congress. I want to say that I have a wonderful memories from the Malaysia and the Kuala Lumpur and also the Chiang Mai Congress the last 2 years ago. Really, COVID is a disaster because need to move from these wonderful experiences to the virtual online. But I think that we need to take profit of this opportunity. And it's for that I congratulate the society for this initiative with a very nice meeting and agenda, and also for inviting me to talk about this topic. Well, you know, colorectal cancer is a very common cancer in all the world. It's about 2 million new cases per year. Probably right colectomy is the procedure most frequently performed, more than sigmoidectomy, because colon cancer, the treatment is surgical. And at this moment, I think that the gold standard around the world is the laparoscopic approach with extracorporeal anastomosis. 7 years ago, we made the first cases of intracorporeal anastomosis in our hospital. But I want to say that this idea is not original. It began many years ago, at least 30 years ago. There were the initial experiences, one of them also, especially by a Spanish surgeon, Dr. Azaga, in 1994, began to consider that intracorporeal should be better than extracorporeal anastomosis. But the question is that there is not evidence about that. Here there are two, but which are the reality in 2020? These are two very recent analyses, and you can see here that in Europe, the amount of patients operated by laparoscopy is about 50%. Most of them are treated with a mechanical anastomosis, and the more third complication is descends with 8%. Also, in a very similar analysis, we found merely the same results. Our reality in Europe is 50% by lab, most of them by anastomosis, most of them lateral anastomosis. But we don't know if intracorporeal or extracorporeal. We make a very short survey around some friends around the world, and also we found this is really fresh data that at least in our ambience, obviously there is an interest in minimal invasive surgery. You can see that laparoscopy was the most frequent performed procedure, but intracorporeal anastomosis was done only in 1 of 4, in spite that we have more than 30 years talking about that. I want to say that this has been also the last experiences on this approach, and there are any randomized control trial. We have more than 30 years talking about that, and I will see, but we don't have any hard data about this situation. The potential advantages of intracorporeal anastomosis is that you require a smaller one to take out the specimen. There is a potential decrease in wound sepsis, less blood loss, more quicker digestive functionality, less pain, less ileum, reduced incidence of incisional hernia, and probably less morbidity. I don't know if there are less incidence of leak, and maybe also to shorten the hospital stay. However, the disadvantages is 3 that very clear. It's most costly because you need mechanical suture for the intracorporeal anastomosis. It's more difficult. This probably, I think, that is the most important aspect, because in many places colorectal surgeons are not skilled to suture, and also it takes more time. You will see here that there are more than 8 meta-analyses and systematic review. Meta-analysis and systematic review of nothing, because they are not prospective randomized trial. And all these papers have a lot of bias, because many of them, the series are very short. In other, at least in cases of really very short series, also the comparison between the patients are not well explained, also including some different clinical situations, also including benign and oncologic patients that require different type of surgery, a different type of anastomosis, changes in the surgical technique, also different definitions of complications, and also most of them, they were retrospective. I want to say that there was a number of bias that I think was a very clear indication to get a prospective randomized trial. The aim of the hypothesis is that intracorporeal anastomosis during laparoscopic right colectomy is a less aggressive technique compared with extracorporeal anastomosis, and we suppose to entail a quicker bowel function recovery, a smaller surgical wound, less pain and morbidity, and maybe short reduced hospital stay. The aims of the study that I will present to you was to analyze the impact on length of hospital stay, the wound length, the bowel function recovery, postoperative pain, analgesia, and 30-day morbidity. This is our experience was a randomized controlled trial, simple blind, comparing intracorporeal with extracorporeal anastomosis with a ratio of 1 patient to 1 patient. It's an unicentric experience with only 1 team. This maybe is a weak point. Probably we need to expand to other centers to really understand that really it's true, the outcomes of this trial. It was performed over the last 5 years, and the sample size with the idea to reduce at least 1 days of stay was 140 patients, 70 patients per arm. And it's very important, we randomize the patients intraoperatively when we know that we could perform the procedure with a series of closed envelopes. The protocol of the trial was published in Colorectal Disease, and the results of the trial that we present now has been recently published in the British Journal of Surgery in the month of December. Something very important of this idea is, in this case, we only use you only perform elective surgery with patients with oncological diagnosis with colon cancer. The tumor was localized in the second, in the ascendant and hepatic flexure, and also to complete a R0 complete resection, only this procedure with ASA 1, 2, 3. And the exclusion criteria was emergent surgery, benign pathology, segmental resection less ileocecal or extended right colectomy, incomplete resection, simultaneous procedure, ASA 4 and stage 4, in order to have really a very coherent population. When we talk about the surgical technique, this is our standard placement of our chokers. We go to control the ileocecal vessels, and so it was a little the right colonic artery and the right branch of the middle colic artery, and then we perform. You can see here the stapler inside the bowel, and we close the anastomosis with intracorporeal with a running suture of a proline 2 O's. And this is the, usually we take out the specimen through a fan steel incision. In the case of extracorporeal anastomosis, the placement of the trocar was the same. Here also we make the same approaches with the vascular ligation of the ileocecal appendicula, the right colon artery, and the right branch of the middle colon artery. And then we perform mini laparotomy, subcostal laparotomy. We make also, in this case, we use the same. Also, we make the mechanical because we wanted to compare the same time of technique. And this is the outcome, the postoperative outcome with this accessory incision here. There were, at this moment, we didn't prepare the patient, so there was not mechanical bowel lavage. The patients were in an enhanced recovery protocol with a standard analgesia protocol. We take a sample of blood during the 3 days. We analyze the morbidity using the Clavian-Guindo and CCI score, and also we had a uniform discharge criteria. This is the results. We consider during this period of time, we consider about 200 patients. Of them, 170 were operated by laparoscopy. Of them, 30 were excluded and were randomized to 1770, and there were only 1 patient lost during the follow-up. And you can see here the patient was, the study was well balanced in relation to the age, male, the age, the sex, also the BMI, the risk, and also the number. More than half of patients had previous abdominal surgery. 70% had some kind of overweight, 70% had also some kind of morbidity, 50% some kind of previous abdominal surgery. And the first outcome, the first important outcome is that intracorporeal anastomosis, at least in our hands, there is some other experience, lasts more. It takes about 26 minutes of difference because the intracorporeal anastomosis is a really delicate procedure. The second, also, we found that after intracorporeal anastomosis, the incision wound was smaller, much smaller than the extracorporeal anastomosis. And I consider that this is an aspect related to the takeout of the specimen. Something that for us was a surprise is that we found a shorter decrease of hemoglobin after intracorporeal anastomosis compared with extracorporeal anastomosis. That means that during the procedure and after the procedure, in spite that the reduction of the hemoglobin was very low, the intracorporeal patients bled more than the extracorporeal. And something also very interesting is that the recovery of the bowel function was increased in the intracorporeal anastomosis. The patient, most of them were treated with the ERAS protocol, but intracorporeal permitted to recovery much quickly the bowel function. Something also for us very interesting is that absolutely intracorporeal anastomosis painless. There is a lot less pain when you compare by the number of doses, but also by this composite analgesic index. That means the overall number of doses that that the patient needs. And this was following a standard protocol, was not at discretion of the surgeon, was following a preoperative pacted protocol. In relation to the morbidity, also, we can show here something interesting. And the extracorporeal anastomosis was followed with much more ileus. You can see here there was a difference of 70% of prolonged ileus after this kind of surgery. And something very interesting that we talk later, and we also found, and this is maybe due to the use of mechanical anastomosis, that the patient with extracorporeal anastomosis bled much more than the patient with intracorporeal anastomosis. We analyze later this fight. In relation to the complications, you can see also here that especially and that the complications were slightly higher, in the extracorporeal group than intracorporeal group, in a space that were not great complications. Sorry. Something that is very important is to talk about the leak. Here, you can see here that the incidence of leak was very similar, and only one patient need to be reoperated. The localization of the tumor was similar, and the stage of the tumor size also was similar. I think that's not too much important, but something that may be some interest is that the number of lymph nodes, the quality of the specimen was similar. There were not differences in relation to the number of lymph nodes that were retrieved. However, you can see that the intracorporeal anastomosis, only 6% of the patient has less than 12 nodes, and with the extracorporeal, 10% had less than 12 nodes. That means that maybe a suboptimal specimen. And the specimen length was slightly longer in the intracorporeal anastomosis group. The hospital stay was similar. We didn't found an impact of the approach on the stay in the hospital, and you can see here also that the readmission percentage was 7%, especially in the extracorporeal anastomosis. Simultaneously with this paper, there is another paper coming from Mario Morino that also with a trial very interesting, because it was a double-blind randomized trial. That thing that is very much better quality. However, in this trial, there is a number of methodological bias, because the type of anastomosis was different with different type of anastomosis, and I think that, and also with different type of retrieval incisions that make really some concerns about this trial. But the most interesting, it was a double-blind trial, and also it shows that the recovery of the bowel function is improved. However, they also couldn't reduce the stay, and also they found the same morbidity between both type of anastomosis. Just some comments when we talk about the operative time. You can see that really intracorporeal was much more longer, and also just is to say that when we comment the different complexity of the surgical procedures, usually the people consider that right colectomy with intracorporeal anastomosis technically is really complex, and that means that you need to have a training for intracorporeal anastomosis or for suturing. I think that something important is the length of the wound, but more important than the length of the wound is that you use differently the wound in the two situations. In one situation, you need to make the wound main incision for the specimen extraction and the anastomosis. That means that you need to manipulate a lot the mesocolon, and that maybe justifies there is much more pain. and also the incidence of wound sepsis and incisional hernia is increased compared with the fat steel that is used only for extraction, no mesocolon traction, no transverse colon dissection, and also reduced manipulation and maybe influence in less pain, also a better aesthetic outcome and less late complications related to this incision. Also, something amazing was the decrease of hemoglobin, and maybe several factors. We consider that the procedure is better controlled with intracorporeal anastomosis. The length of anastomosis also may be a relationship, and also I think that is very important the type of anastomosis. You can see here that you use in the same, we consider that we use the same anastomosis, but because we use mechanical blue cartridge anastomosis. However, it's important to say that intracorporeal anastomosis has the same height of the staplers, but he has 3 rows. And extracorporeal anastomosis, it has 2 rows. And maybe this anastomosis is more hemostatic than this one. And because you can see that we found much more bleeding in the group with extracorporeal anastomosis than intracorporeal anastomosis. Something also from the oncological aspects, there were not too much difference, but sorry.
Eduardo, we are running out of time.
Yeah, very close. Very just conclusion. Okay. Thank you. Sorry. Well, anastomosis, in our opinion, intracorporeal anastomosis requires longer surgical time, but permit to retrieve a better quality specimen, maintaining the oncological standards. The recovery of the bubble function and is speeded with intracorporeal anastomosis. We consider that is a less aggressive technique, and we consider that is a better approach, but requires a good training, and probably also we require a better multi-center studies to confirm these studies. Just to finish with this slide, thank you very much for your invitation. I invite all of you to the World Congress in Barcelona next July, and my feeling is to try to organize a presential Congress, but I'm not sure about that. In the case that no, we will share a virtual Congress. Thank you very much for your attention.
We will come anyways. So sorry, the time is up, so we don't have time for discussion or questions. Back to the organizers. Thank you very much, Edouard.